Hi class, welcome to Unit 3 where we're going to start our cardiac content, and we're going to start off with assessment of cardiovascular function and a little bit of a review, some material that you should have had in A&P and then again in pathophysiology. Alright, so overview, remember there's 3 layers to the heart, 4 chambers. We've got 2 sets of valves. You've got your AV valves, the tricuspid and mitral, and your semilunar, which is your aortic and pulmonic. We've got the coronary arteries that wrap around the outside of the heart to perfuse those muscle layers. Then we've got the cardiac conduction system, and that's the electrophysiology, so what generates the electric impulse to generate each pulse. And then we've got cardiac hemodynamics, so the flow of the blood around the body to maintain adequate perfusion. So let's first look at the anatomy. So this picture has a lot of details on it, but in a nutshell, it's got the right versus the left side of the heart. The right has unoxygenated blood. The left has oxygenated blood. That's why the right side is blue, left side is red. You've got the 4 main chambers. You've got the right atria, right ventricle, left atria, left ventricle. And then you've got the 4 valves. The tricuspid and mitral are AV valves because they're between the atria and the ventricles. And then you've got the aortic and pulmonic. Those are your semilunar valves, and those are what go to the heart and from the heart. So just some review. I do want to just say that the left ventricle is a very important chamber, and in this picture they've done a nice job of showing you how thick that muscle is on the left ventricle, because the left ventricle is what gives us good cardiac output or perfusion to the body, and that's why that left ventricle is a thicker muscle. This is just a diagram that shows you the blood flow through the heart. That's something important to know, and then that way you can understand if there's a pumping problem, where is it going to have insufficiency, where is it going to have backup to. Then we've got a reminder for the valves of the heart. So you've got the way you listen, the cardiac landmarks, and those are where you can best hear those valves. And then you've got, and that's ape to man, and then you've got the cardiac blood flow, and that's the way they actually flow through the heart. So it's 2 different snapshots, 2 different things to remember. So ape to man is where you auscultate. Tissue paper, my assets is the actual blood flow sequence. And remember that the valves have to coordinate blood being moved forward, so all of them have to open and close in a coordinated manner. And the big risk for valve problems is if someone has had a history of rheumatic fever. If you ever see that in a person's chart, you want to think, have they had any difficulty with their heart valves? Do they have any murmurs? And so this is just a bigger picture of how the blood flows through the heart, and then it breaks it down pretty simply to what goes to the body, what goes to lungs, and what goes back out to the body. And then it also ties in the fact that for adequate perfusion, we also need to be assessing the legs, ankles, and feet. So it's important to know the location of each valves, because those valves are responsible for maintaining forward blood flow through the chambers of the heart. They open and close with pressure and volume changes within the heart. The valves also protect backflow and keep things moving forward. So then there's murmurs. Murmurs reflect turbulent blood flow through either normal or abnormal valves. There are 2 common types of murmurs. systolic and diastolic, and they are graded according to their level of loudness. And they go from grade 1, which is very faint, to grade 6, which is extremely loud. And when you listen to a murmur, it sounds like rushing, a rushing noise, and that is the sound that blood makes as it's moving through a narrow place. So an important connection between the valves, murmurs, and auscultation, and the flow of blood. All these pieces go together. And then layer on top of that is the electrical conduction of the heart. The cardiac muscles are unique, and I'm not going to review that in great details, but I will talk about a little bit on the next slide. But basically, the heart muscles can hold a conduction, and then that triggers a cascade or impulses to be fired to move through the chambers of the heart to trigger the heart to contract. The sequence that you need to know is it all starts with the SA node. That's the heart's normal pacemaker. From the SA node, it travels through the atria to the AV node, and then from the AV node, it goes to the bundle of His, and from the bundle of His, it travels down the Purkinje fibers to the right and left ventricles. That is the specific sequence of events that happen with a normal conduction system. That's the expected pathway that these electrical impulses should take. And I'm going to talk about this in great detail on my EKG record seminar and in lab, but this is very important fundamental information to understand. It ties into the cardiac action potential. So that's just the fact that it can conduct electrical activity. And there's depolarization, repolarization, and then a refractory period. And you can see these on an EKG, and we're going to talk about it. Depolarization is contraction, repolarization is rest, and refractory period is the period where we can't do another impulse until the electrical potential has returned. And so we'll talk about that in terms of the EK strip, but those are some important terminology to be familiar with. And then it all rests in a cardiac cycle. One cardiac cycle refers to the events that occur from one heartbeat to the next. The number of cycles, it depends on the heart rate, how fast is it beating. There are 3 major events that happen in each cycle. You've got diastole, you've got atrial systole, and ventricular systole. So diastole is at rest, systole is contraction, and it starts with the atria and then it transitions to the ventricles with that electrical impulse. It's also important to know that when talking of basics, know that the systolic blood pressure is the amount of pressure or force generated by the left ventricle to distribute blood into the aorta with each contraction. Diastolic blood pressure is the amount of pressure or force against the arterial walls during the relaxation phase of the heart, and that's typically when the filling occurs of the ventricles and the atria. Then we've got cardiac output. Cardiac output is really important to understand what components of it. So there's stroke volume, that's the amount of blood ejected with each heartbeat. Then there's preload. Preload is the filling volume of the ventricle, and it's dependent upon blood returning to the heart. Then there's afterload. That's the resistance that the heart has to pump against, and it depends on the body's blood pressure. And then there's contractility, and that's the heart's muscle strength and ability to stretch. So cardiac output equals stroke volume times heart rate. Control of heart rate is a complicated process. It has to do with the autonomic nervous system, baroreceptors, electrical conduction. Control of stroke volume. With preload, there's the Frank-Starling law, and that states the more the heart muscle stretches, the better for contractility upwards to a point. And a way to think about that is if you're stretching a rubber band, you can stretch it up to a point and you're going to have a much bigger snap, but if you stretch it too far, it breaks. That's kind of what they're talking about with the Frank-Starling law. Contractility is increased by catecholamines, the central nervous system, certain medications. If you have an increase in contractility, you will have an increase in stroke volume. If you have a decrease, which is typically caused by hypoxemia, acidosis, certain meds, you'll have a decreased stroke volume. And then there's also afterload, which is affected by systemic vascular resistance and pulmonary vascular resistance, so the blood pressure in the body. And then just a reminder, cardiac output is the amount of blood pumped by the heart per 1 minute. Cardiac output is important because it is the amount of blood pumped from the left ventricle each minute, and then the formula to figure that out is stroke volume times heart rate. That equals cardiac output. Variables that affect this are the heart rate, preload, afterload, contractility, and these are the foundations. One thing I want to touch base on is ejection fraction. That is typically measured in the left ventricle, and it is the percent of the end diastolic volume that is ejected with each heartbeat. So how much blood is actually being pumped out in a percentage? And that's something that we look at with heart failure. If the number gets real low, you know you're going to have decreased cardiac output. If you have a patient that has a heart attack and it involves the left ventricle, we will expect a decrease in cardiac output too, because we've lost some of that oomph, some of that muscle strength in that left ventricle. So all these factors come into play to perfuse the body adequately. And that brings me to the assessment component. So for a perfusion assessment, the physical assessment is critical. All numbers must be correlated with the patient condition. You have to treat the patient, not the numbers, because your patient will show signs and symptoms, and then there can be a lag time before those lab values or numbers correspond with what the patient is experiencing. These numbers also need to be trended over a period of time to notice for changes in pattern. So like if you have a patient who at the beginning of your shift, their pulse rate is 72. When you take it again 2 hours later, it's now 84. Then you take it 2 hours later after that, it's now 91. That's a trend towards tachycardia, and we would want to address it, do a good assessment, and notify the healthcare provider so we can take action before it actually gets to over 100 and then full tachycardia. So that's just an example. You can do that with all the vital signs. You can do that with SpO2. SpO2 measures the percentage of oxygen that is bound to hemoglobin and determines hypoxemia, not hypoventilation. If you have a low SpO2 in your patient, that is a late sign of cyanosis. So we don't want to wait for the SpO2 to get low. You want to assess those respiratory rate, depth, adequacy, the signs and symptoms in your patient. Don't wait for the SpO2 to drop to do something. And if you doubt the accuracy of an SpO2, you should request an ABG, because the ABG is the gold standard to determine the level of oxygenation in the body. The respiratory rate, you're going to ensure adequate rate and depth and quality, I would say. Blood pressure, you always want to do your first blood pressure as a manual. And you should know that a blood pressure doesn't decrease until 30% of blood volume is lost. A drop in blood volume is a late sign of hypovolemia, heart failure, or shock. So those other assessments are critically important. Orthostatic hypotension. Just to name one, adequate pulses to the feet is another, etc., etc. Pulse rate, rate and quality. Is it bounding? Is it weak? Peripheral pulses, radial and brachial, they are palpable if the systolic blood pressure is greater than 80. Femoral pulse is palpable if systolic blood pressure is greater than 70. Carotid pulse is palpable if systolic blood pressure is greater than 60. So just being able to assess peripheral pulses tells us about adequate perfusion to the body. And if they lose pulses in their feet, you have to move upwards to what's the next thing that's going to be affected, and do they have a good pulse there? Because as the blood pressure drops, the body shunts blood to the major organs to protect that. That's going to be your heart, your brain, and your lungs, not the kidneys. Moving forward, skin, is it pale or cool? I want you to think decreased perfusion. That's a red flag. Brain, it is extremely sensitive to two things: a lack of glucose and a lack of oxygen. Critical, check first for confusion or altered mental status, and then think oxygen and glucose. And then lastly on this slide, kidneys. Kidneys is one of the best ways to monitor perfusion, and they must have 0.5 milliliter per kilogram per hour at a minimum. Preferred is greater than 1 milliliter per kilogram per hour. Back in the day, we used to say a minimum of 20 to 30 milliliters per hour, but that's not quite as accurate as doing a weight-based calculation. So I can't stress keeping a close eye on kidney function enough, because it goes back to how the body protects itself and shunts blood to protect the vital organs, and the kidneys aren't considered a vital organs. And that way, if you have a patient that's becoming shocky, you're going to see a decrease in urine output. So really super important stuff to do as part of a standard perfusion assessment. Then we've got the whole cardiac assessment, where it's got a lot of different components. All of them give you insight into changes due to cardiac problems. So a big one is edema. Patients may say that their shoes don't fit well, or they're experiencing weight gain. If they're taking a diuretic, we've got to tell them that diuretics affect their potassium level. And if they're on a thiazide or a loop diuretic, we want them to eat foods high in potassium. We also need to educate these people, if they take a diuretic, they need to drink adequate water, because especially in the elderly population, they have a diminished thirst mechanism, and they can become dehydrated, which causes confusion in the elderly. If there's a change in someone, in their status, always do a medication reconciliation. If someone is having lung problems, auscultate those lungs. If they are having crackles or shortness of breath, I want you to think maybe they have a heart failure issue. Heart failure patients may report shortness of breath with climbing stairs. This it's just something we need to be mindful of and determine, are we dealing with a lung problem or a heart problem? So a lot of times heart and lung assessments go hand in hand. Blood pressure can be another component, which increases the risks of heart attack and chest pain. Chest pain occurs after physical exertion, and it is related to the increased oxygen demands. Okay? So when you have physical exertion, you need more oxygen. That stresses the heart, triggering chest pain. Let's see. Coronary artery disease. If your patient has a history of coronary artery disease or a new diagnosis, we've got to do patient education about what are acute cardiac problems, how do you treat their chest pain, what to do about it. One thing that I want to touch base on too for blood pressure is if you do assess their lower extremities, look to see if they have hair. If they have hair loss on their legs, kind of patchy hair loss, that's a symptom of decreased perfusion. Or if they have mottling, that's an indication of poor blood circulation. So the skin, the nails, the lower extremities, the legs, feet, the lungs, all these things are critical cardiac clues to what may be going on in a patient, and critically important for assessing perfusion. Also, please remember that when you're assessing heart rate, don't forget that if you have a low blood pressure, the heart rate is going to be elevated to compensate for the low blood pressure. Okay? So that's a very common scenario. They have a low blood pressure, high pulse. And then as we stabilize them, if it's due to low circulating volume, give them some hydration, that pulse should decrease and stabilize. So a lot of complicated things to consider. Another thing is people that have coronary artery disease, if they have low blood pressures, they're at an increased risk for having angina or chest pain. And that's due to the decreased perfusion to the cardiac arteries related to a low blood pressure. So a lot of things to consider. I hope that these details help make sense of why a good assessment is just so important, and not necessarily wait until you see a big change in vital signs or laboratory values. This one I wanted to just touch base on, carotid bruits. So that's when we auscultate the carotid arteries on the either side of the neck. If you hear a bruit, it's caused by turbulent blood flow in an artery that supplies blood to the brain. And a common cause is aortic stenosis related to atherosclerosis. If you detect this, you need to report it to the provider immediately. This patient may need emergency carotid surgery. So what that means is there's plaque in the main blood vessels that perfuse our brain. That's a big, big red flag. They're at a high risk for a stroke. And that's why we need to report that finding to the provider immediately. I touched base on orthostatic hypotension. I just wanted to reiterate what that means to make sure you remember that. So we do a series of blood pressures and pulses. You assess it first laying flat, then you have them sit in a chair, then you have them stand. So if you have a 20-point drop in systolic blood pressure, or a 10-point drop in diastolic blood pressure, that is orthostatic hypotension. And as I've mentioned, if the blood pressure goes down, the pulse will go up. Something that predisposes patients to orthostatic hypotension, your medications. Diuretics and antihypertensives, for example, beta blockers, ACE inhibitors, angio-2 receptor blockers, all of them can cause orthostatic hypotension, as can dehydration. And if someone tells you that they feel lightheaded or dizzy upon sitting or standing, we want them to take a moment, orient themselves before taking a step, because they're at risk for passing out or falling or hurting themselves, that sort of thing. Then critical point to remember is the best indicator of fluid balance is weight. And I want you to remember that 2.2 pounds equals 1 kilogram, and 1 kilogram is equal to a liter of fluid. And so we encourage daily weights in cardiac patients, specifically those with heart failure. And we want to make note of any significant changes. What we're usually looking for is weight retention. Going up 1 kilogram in 24 hours means they've got an extra liter of fluid on board. And then usually if it's over a week, we look at 5 pounds, a 5-pound change in a week. So usually we say a 2-pound weight over 2 to 3 days, or 5 pounds in a week. Those are red flags and reasons for a heart failure patient to notify their healthcare provider. And usually the go-to action is that they order a supplemental dose of a diuretic to help get that fluid off. And then a lot of times we use fluid restrictions to minimize excess fluid intake. Okay, this is just a review of what I already told you about murmurs. Murmurs are a rushing sound that is made as blood moves through a narrow place, such as a heart valve, and it's graded on how loud it is. Let's see, then we've got our laboratory values for cardiac. So the big ones are your troponin. You can have troponin I, troponin T. Both of them are proteins found in heart muscle, and they're released into the blood when there is damage to the heart. So troponin is highly specific to cardiac damage and is typically the gold standard of what we assess. The next one that is less specific than troponin, so it's not used quite as much for myocardial infarctions, but can help determine muscle damage, is the CK. CKs can be elevated with indeterminate types of muscle damage too, like a side effect from statin medications, or if your patient is having rhabdomyolysis. We're going to take a look at the lipid panel, your HDL, LDL, triglycerides, and total. The BNP is your best indicator of heart failure. A negative is usually 100 or less. Your C-reactive protein is an indication of inflammation. It's a general marker. It's not specific to where the inflammation occurs. That has to be correlated with patient signs and symptoms. And then homocysteine is it is a tool that helps the physician evaluate general cardiovascular risk. Let's see. So those are the most common cardiac related labs that you're going to need to be familiar with. Looking at lipid levels, it is important to have some general knowledge about these specific values. And you need to know what puts someone at a risk or an elevated risk or a high risk for heart disease. And I want you to review atherosclerosis. Atherosclerosis is a combination of platelets and fat that accumulates in blood vessels, narrowing those arteries and reducing blood flow. And remember that if anyone has an elevated lipid level, diet and exercise are always the first steps for treating elevated cholesterol. But we do need to consider familial tendencies. Sometimes it just runs strongly in families and we don't fully understand the reason behind that. And then if diet and exercise isn't adequate, we will turn to our cholesterol medications like simvastatin, otherwise known as Zocor, for one example. And remember with statins that you have to tell the patient to report muscle pain or aches because that is a symptom of rhabdomyolysis. And remember with statins, we need to check liver functions because it's primarily metabolized by the liver and cause elevated liver functions. Another value or diagnostic tool is the electrocardiogram, abbreviated EKG, ECG. There's several different ways to get this. One is a snapshot picture. It's like a one-time order. You get a 12-lead EKG. Then there's different continuous monitoring. Excuse me. There's like a telemetry. Telepack is sometimes what they're called. Those have 5 leads or 5 electrodes that attach to the body. There are lead systems, like you can have a 3-lead one. And then there's, if they're going to be sent home with cardiac monitoring, they could be sent home on a Holter monitor. EKGs are most helpful and most accurate when the patient isn't moving. And so that's why when you have a 12-lead EKG, the patient needs to stay completely still to get the best picture because the EKG senses electrical conduction and also movement. And on the bottom of this slide is just a picture of normal sinus rhythm on EKG paper strip. Another diagnostic test is a stress test. You can do an exercise one or a pharmacological one. With a stress test, sometimes called a treadmill test or an exercise test, it helps the doctor find out how well their heart handles an increase in workload. And so they start out very slow and then increases how hard the body has to work. And as the body works harder, it has an increased demand for oxygen and increased demand for blood supply. So they'll monitor the oxygen level, the blood pressure, and the heart rhythm. And what they're looking for is electrical conduction changes that indicate inadequate blood flow in the coronary arteries. And usually what is most commonly associated with that is ST segment elevation or depression. ST segment elevation or depression signifies ischemia to the heart, and we would stop the test. And I'm going to talk more about ST segment in my EKG recorded seminar. And if your patient is not able to walk on a treadmill, we can do a pharmacological stress test that we give a medication to mimic the dilation of blood vessels that would occur if the patient was exercising, and then we look for the same symptoms in the patient. Let's see. Then we've got an echocardiogram. Echocardiogram is a non-invasive procedure. It's basically an ultrasound of the heart to assess the structure of the heart and the flow of the blood through the heart. You can do transthoracic, which is just the external part of the chest, or you can do transesophageal. That one requires some sedation, is a higher risk procedure. Then we can do cardiac catheterization. That is an invasive procedure in which we access a blood vessel, thread a catheter through the blood vessel up into the heart so that we can visualize the coronary arteries and look for any obstruction. And the way that we do that is that we use IV contrast. It uses a fair amount of IV contrast. So because we use contrast with cardiac catheterizations, we have to do a renal function assessment and assess for use of metformin, because metformin used with IV contrast can cause renal failure. So the next few slides are going to offer you some insight into cardiac catheterization. So this is a picture to show how they access the blood vessels and thread them up. So what they do is they either access through an incision made in the groin or in the wrist, and then they insert the catheter and thread it all the way up to the heart. That's what is pictured on the left side of the screen. On the right side of the screen, it shows you the IV contrast flowing through the coronary arteries, and the size of the vessel, how big it is, shows us whether the blood can flow through it or whether it is blocked in other areas. It's the contrast that shows up on the continuous x-ray that gives us this picture. So prior to this procedure, some nursing considerations is they may need to have a Foley catheter, especially if they have a history of renal insufficiency. They're going to need at least one peripheral IV. You're going to be having some IV fluids. You're going to need laboratory results on the chart. You're going to need to assess them for iodine or shellfish allergies. This is the two main ways. The wrist one has become more popular because after the incision is made and the patient is discharged from the cath lab and sent back to the nursing unit, they have to remain flat for 6 to 8 hours. And so it's really hard to keep that leg perfectly flat and relaxed for 6 to 8 hours. And they've had better success with resting one wrist. So that 6 to 8 hours of rest, the patient can't even raise their head very high because it increases the amount of pressure on that blood vessel and they could bleed. So after the procedure, the nursing considerations is they are at a high risk for bleeding. One is because we will usually give them blood thinners while they're in the cath lab. And two, we've just made an incision over a major blood vessel. So they're at high risk for two types of bleeding: hematoma formation at the insertion site or bleeding elsewhere due to the anticoagulants. And so what we have to do is check those peripheral pulses very, very frequently and the color and temperature of the extremities. It is potentially possible for a small piece of lipid or clot to break off during this procedure and travel and cause a blood clot somewhere or even a stroke. So we need to be especially mindful if the patient becomes confused, disoriented, slurring their speech, or any other neurological symptom, because this could be symptom of a stroke and need to be acted upon emergently. So there's a lot of post-catheterization care that is critical assessment that must be done after a patient has returned from the unit. Let's see, this slide talks more about the pre-op considerations. They're going to have to sign a consent. We're going to have to verify the shellfish iodine allergy, place a Foley if there's any question about their renal function. And the reason why the Foley is helpful is because we don't have to wait for the patient to go pee. We can continually assess their urine output with a Foley being placed. We're going to do IV fluids, lab values. We're going to assess and mark those peripheral pulses so that we can go back and reassess them quickly. They're going to be NPO for 6 to 8 hours of solids, 4 hours for liquids. We're going to need a height and a weight for contrast calculations. The certain insertion site's going to have to be shaved and cleaned, and we're going to need at least one peripheral IV, if not two. And this picture shows you the blood vessels and the balloon that can be used to kind of open up a blood vessel again. And if you look on slide A, you can see there's a blood vessel in the middle of the picture, and it just kind of stops abruptly. And then in B, you can see the catheter being threaded and then the balloon at the bottom. And then after that, you can see that blood vessel now goes all the way down to the bottom of the picture because we returned the blood flow by opening up the closed area. Just to reiterate on post-cath assessment, bleeding site for hematoma, bleeding, pulses, color, temp of leg, potential complications, everything that I already said. Hitting it home again. Monitor for chest pain, bleeding, kidney problems. Assess and then act. Usually vital signs are done every 15 minutes times 2, 30 minutes times 2, and then hourly for 2 hours or some variation of that. So it's really very, very close assessment after they have a cardiac catheterization done. Let's see. Then this slide talks about hemodynamic monitoring, and this is typically what you'll talk about in Lisa's class next term when we talk ICU. All right, so that brings us to the next section. All right, so the first thing is just a little bit of a review of the vascular system. We've got the right side of the heart, the left side of the heart. We've got the arteries, the veins, capillaries, and lymphatic vessels. It's good to be familiar with all those. We've got the function of the vascular system. So circulatory needs, blood flow, blood pressure, capillary filtration and reabsorption. And the hemodynamic resistance, peripheral vascular regulating mechanisms, all these things are good things to go back and review and make sure you have a basic understanding of how these symptoms work and what can go wrong. So what could go wrong? You can have a pump failure. So the heart could not be pumping correctly or adequately. You can have alterations in the blood and lymph vessels. You can have inadequate circulation to the extremities. Remember that the systemic and pulmonary circulation are all tied together. Everything flows into each other. We kind of touched base on this with the GI unit, and we talked about how liver cirrhosis and portal hypertension can lead to esophageal varices. And remember, everything is connected. Everything flows together. There are some things that happen in the aging process that you want to be mindful of. So aging produces changes in the walls of the blood vessels. They cause to kind of stiffen a little bit, less flexibility. So it makes the resistance increase, and it can impede adequate blood flow. And that increase in resistance outside the heart can increase the workload, how hard the heart has to work in order to pump blood out. So those are some intrinsic aging considerations. Assessment of the vascular system. This should be pretty much a review from term 4. I think you learn quite a bit about peripheral vascular disease in term 4, so I'm not going to go real in depth of that. Review how to assess those pulses. Remember that when you assess pedal pulses, do both of them at the same time so that you can detect any changes between the left and the right side of the body. Can't stress that enough. Huge, huge thing. There are some diagnostic tests that can be done to detect these problems. And again, you should have either heard about these in Term 4 or you can read about them in your book. This is one that is fairly popular, a Doppler ultrasound to assess blood flow, and that can help figure out how severe someone's peripheral vascular disease is. And this is not something that your average floor nurse does. Usually you have specialty training to do these sorts of things. But it's non-invasive and it gives us good information about their blood flow. Peripheral artery disease. It alters the natural flow of blood through the arteries and veins of the peripheral circulation, and it's usually the result of systemic atherosclerosis. What happens is the large peripheral arteries become narrowed and restricted, also known as stenosed, and that leads to temporary or acute or permanent chronic reduction in blood flow, which is ischemia. It's usually atherosclerosis related, but it can also be related to clots or inflammation. This problem is more common in people that have diabetes, hypertension, hyperlipidemia, in older adults, and smokers. Plaque buildup can happen in many places in the body, but it is most common in the lower extremities. The symptoms usually show up once a blood vessel is 50% occluded. The key symptom is intermittent claudication, and intermittent claudication gets worse when you have pain that occurs even at rest. And they could report symptoms like numbness or burning too. Just to contrast venous versus arterial insufficiency. So the color, the temp, the pulse, the edema, the skin changes, kind of know those main categories. This slide shows you the common places of those atherosclerotic lesions. And the signs and symptoms that are most commonly associated are intermittent claudication, weak or absent pulses, decreased skin temperature, pallor or mottling, redness when in a dependent position, and hair loss. There are some pharmacological interventions, some medications we can turn to help manage these conditions. And again, I'm not going to go into a real big detail because I think we covered the aspirin, Plavix, and statins pretty well. Ways that we can improve peripheral artery circulation: exercise, gentle exercise. You have to consult the primary healthcare provider before prescribing exercise. We need to educate these patients to notify of any signs and symptoms like numbness, paralysis, or pain. We need to educate them to stop smoking. We need to educate them to not wear any tight clothing, including knee socks, waistbands, shoes. They need regular foot examinations and podiatry visits. And we need to caution them against hot and cold temperature, including with baths. Because of the decreased sensation, they could burn themselves or hurt themselves and not even know it right away. These are just kind of a laundry list of different arterial disorders that can happen, and we're going to talk about some of them in more detail. So I've talked a little bit about atherosclerosis. There's also arteriosclerosis. Just to know those two terminologies. There is a progression of this these disease processes, and then there's the risks of what could go wrong. So you can see it's a gradual buildup. It starts with the fat, then it's fibrotic, and then there's thrombosis potentially obscuring the blood vessel completely, and then we can see problems like heart attacks, strokes, or gangrene in the feet. That's a big one. So let's just hit those risk factors. So we've got modifiable, non-modifiable. I would be familiar with these. Then we've got aneurysms. Aneurysm is a weakening of part of the wall of a blood vessel, and that causes or results in a balloon-like bulge. And as blood flows through over time, it's a turbulent blood flow, and that can dilate the area even more, making it bigger. And then that can disrupt blood flow to everything below the affected site or even cause death. Aneurysms are related to atherosclerosis, smooth muscle degeneration of the aorta, trauma. There could be a congenital problem or an infection that develops. This next slide is just a picture of the different types of aneurysms. They can look very differently, and there's different names for each of them, but all of them have the same risks. One that is especially dangerous is your AAA, ascending aortic aneurysm. If your patient has a AAA, the pain is usually steady with like a gnawing quality. It's typically unaffected by movement. The pain can last for hours or days. That pain can be in their abdomen. It could be flank pain. It could be back pain. The abdominal mass could be pulsating and should never be palpated. You never palpate a AAA. And because rupture is the most frequent complication, and rupture is life-threatening. So signs and symptoms that things have escalated is severe back or abdominal pain. If you can see a pulsating mass, you may be able to auscultate a bruit over the area. Severe hypotension and syncope will occur if it does rupture. And unfortunately, these patients rarely live if it does rupture. And if they do, it's a very long recovery from a ruptured AAA. Usually what we do is we go in and we surgically repair it. And after the surgery, they are on very strict lifting restrictions for 3 months. And the reason why is because lifting could cause those sutures to weaken and open, and it would be just as bad as if it had ruptured. There are aortic dissections. Those are a sudden tear, and the pain is described as tearing, ripping, stabbing, severe. This is life-threatening, so you're going to do your emergency care. We're going to try and reduce the blood pressure because it's going to be less blood being pumped out of the tear. And we're going to decrease the left ventricle ejection, again, to decrease the blood flow. And usually it's a surgical treatment, most commonly, going in and suturing up that dissection. To switch gears to a non-life-threatening disease is Raynaud disease. Raynaud's is the big thing with that is there's going to be ineffective tissue perfusion, usually in the fingertips and toes. So what happens with Raynaud's is it's caused by vasospasms of the little tiny arteries of the upper and lower extremities. It causes some areas of the body to feel numb and cold in response to cold temperatures or even stress. In Raynaud's, the smaller arteries that supply blood to the skin are narrow, limiting blood circulation, and it can be causing vasospasms, which can kind of hurt. Women are more likely than men to have Raynaud's, It's more common in people that live in cold climates, and the treatment is dependent upon its severity and whether the patient has any other health conditions. Anyone that has Raynaud's should wear warm clothes and stay away from cold. It can be painful, and on the next slide, I show you we can see the Raynaud's in the fingers are going to be either pale or blue or red, and they may report numbness and tingling. And of course, this can happen in the toes too. And it's often recommended that these patients relocate to a warmer climate if possible. All right, so then let's go to venous disorders. Super common, embolisms, venous insufficiency, leg ulcers, varicose veins. We would say thrombus, thrombophlebitis, deep vein thrombosis, pulmonary embolisms, all these could fall into it. I would probably say leg ulcers are really becoming super common, especially with the number of diabetic patients that are in the U.S. And with any type of ulceration, you want to assess the location, the type of pain. You want to compare legs bilaterally, assessing pulse and temperature. And with these, you also want to say, are there any mobility issues? Is there anything else that we need to address that's causing it harder for them to get around? And I wanted to just mention to you something called Virchow's triad. Virchow's is spelled VIRCHOW''S, triad. And basically, there's 3 things that have to happen in order for a clot to form. You have to have stasis of blood, so pumping isn't like it usually is. It's not perfusing, it's not moving. You've got stasis. Hypercoagulability, so an increased risk of clotting, and then injury to somewhere, to some tissue, to some blood vessel. Those 3 things happen, and they are at a high risk for developing a clot. And that's the first thing we're going to talk about. So what they'll usually complain of is tenderness or pain at a specific location. It can be sudden. You can also see unilateral swelling of a leg. So one leg is swollen, the other one isn't. That's why bilateral assessment is so important. There could also be localized edema. If any of these redness, swelling, tenderness, pain, and then the swelling ties in, we're going to think possible VTE, and we're going to do ultrasound usually to assess the blood vessel and look for clots so we can look at the blood flow. One thing I do want to touch base on is Hohmann's sign. If you guys remember that, we don't do that anymore. So don't ever assess Hohmann's sign. Some other tests that we can do are a D-dimer. A D-dimer will be elevated if there is a clot present. And usually what we do for treatment is heparin. Heparin is often prescribed for DVTs, and then they will bridge the patient over to Coumadin for a more long-term anticoagulant. Heparin's usually given for 5 to 10 days, and on the 3rd day, they start the client on Coumadin. The goal is to reach a therapeutic INR of 2 to 3. If a patient on heparin develops sudden excessive bleeding, you will need to be prepared to draw a PTT and give protamine sulfate, which is the antidote for heparin. If they're also on Coumadin, you have to be prepared to draw a PT-INR and give vitamin K, which is the antidote for Coumadin. You need to know these. Both heparin and Coumadin are high alert medications, and I highly recommend having a second RN double check your dosing. And then there is also Lovenox. Lovenox can also be used. Usually it's patients are discharged to home on Lovenox. Remember, Lovenox is low molecular weight heparin, and it doesn't require lab values the way heparin does. Let's see. We could also do an MRI too, if an ultrasound is inconclusive. Let's see. What can we do to prevent these from occurring? Well, we can wear TED hose. We could use SCDs, getting people up to walk early and frequently when they're hospitalized. We could use a low dose of subcutaneous heparin or Lovenox. We can recommend lifestyle changes, weight loss, smoking cessation, exercise. Obviously, those take more time. Then let's switch over to varicose veins and just touch base on that. To prevent them, which is ideal, avoid activities that cause venous stasis. If you can, elevate your legs higher than your heart. Walk 30 minutes every day. Wear TED hose. Overweight patients should be encouraged to reduce weight. For all of you, being that you're going to be nurses, I really recommend wearing TED hose. Okay, so sorry, I had to pause for a second there. As I was saying, for all nurses, being that we work 12-hour shifts usually, wearing TED hoses can really help us prevent varicose veins in the long run, just as a side note. And if you have any patients that work retail, factories, that kind of thing, this could be a good thing to do too. Varicose veins aren't deadly, but they can really hurt, and there's treatments available, but it can be costly. So prevention is probably the easiest way. I'm just going to touch base on the lymphatic disorders. So you can have inflammation of the lymphatic channels or of the nodes, or you can have lymphedema. And usually if there's a lymphedema problem, we do wraps to help reduce the swelling. And it really, lymph disorders is its own speciality, so I'm not going to go real in depth, but you can read more in your textbook about this condition. Then there is cellulitis. Cellulitis is a little bit more of a general diagnosis. You can see localized redness, swelling. If it progresses, you can get fevers, chills, sweatings. It can develop into sepsis if we don't treat it promptly. If it's small area, caught early, we can use oral antibiotics. If it's progressed, IV antibiotics are going to be necessary. We can do some comforts. We can elevate the affected area, moist packs, educate them on the signs and symptoms of early infection. Tell them not to pick at stuff, not to squeeze ingrown hairs, that kind of stuff. Good skin and foot care is important because that's usually what triggers a cellulitic type infection. From there, I think the rest of my presentation is a review of medications. So cardiac meds is usually a sticky point. There's so much to remember, and so I wanted to just take a few minutes and talk about the most commonly prescribed cardiac medications. So on this slide, I've got 4 classes, and I would take a look at this slide because it's got really good key point information to have at the forefront of your mind, and I'm going to talk about each of these on a separate slide. So what I'm going to talk about are select treatments specifically for hypertension, and a lot of these carry over into post-MI care because we want good blood pressure control. Usually, I do want to say that if you have a patient with slightly elevated blood pressure, like in the upper 120s to 130s, we always start with lifestyle modification, so be sure to take a look at that in your textbook. Otherwise, we can turn to diuretics, beta blockers, calcium channel blockers, ACE inhibitors, angiotensin II receptor blockers. Antagonist and blocker are kind of used interchangeable. Just a reminder of that. One thing I always want to remind you guys of is beta blockers can be cardioselective or non-cardioselective. If they are cardioselective, it means they only affect the heart primarily. If they're non-cardioselective, they can affect the heart and the lungs. Both type of beta blockers we need to assess for the risk of bronchospasms, but we would not prescribe a non-cardioselective beta blocker to anyone with asthma or COPD because it will affect their lungs. So important consideration. From there, I want to start off by talking about diuretics. Diuretics are first-line treatment for hypertension. They're useful for edema. They're useful for a lot of cardiac condition. They're sometimes used for people that have low urine output or low kidney function to help increase urine production. There are 5 classes of diuretics. The top 3 are what we're going to focus most of our time and attention on. The last 2 just aren't prescribed very frequently. So the last 2, the osmotic, that is used to treat cerebral edema. The carbonics are used to treat glaucoma. So not this week's topics at all. So let's dive into thiazide, loop, and potassium sparing. Thiazide. An example of a thiazide diuretic is hydrochlorothiazide. They all end in thiazide. What happens is the thiazides cause the body to excrete more sodium, and it pulls water along with the sodium being peed out. Therefore, there is a decrease in circulating blood volume, and this can be used to treat heart failure, hypertension, most commonly. Thiazides also decrease calcium levels, potassium levels. They may increase blood glucose levels and can cause low sodium levels. So your big 3 electrolytes you want to focus in on with a thiazide is first and foremost potassium, then sodium and calcium. Those 3 levels can all be affected. Moving on to a loop diuretic. Loop diuretic example is furosemide. They all end in samide. These ones are more potent than a thiazide. They're well absorbed, highly protein binding. They work on the loop of Henle, and they produce a large amount of diuresis or urine. They increase secretion of sodium chloride and water. They can cause dehydration, orthostatic hypotension, high uric acid levels, low potassium, low sodium, low calcium. These are used to treat edema, heart failure, hypertension, edema related to liver disease, and edema related to kidney disease. The third and last one on this slide is potassium sparing, spiroaldactone or aldactone. These are weaker and they conserve potassium. They in turn excrete sodium, water, chloride, and calcium. These can be used to treat edema, hypokalemia caused from other diuretics. They can be used to treat cirrhosis, kidney disorders, hypertension, heart failure. So that's a quick review of the diuretics. One thing I want to touch base on, all diuretics, you have to do the following, because diuretics' purpose is to get rid of excess water and sodium through urination. That has the benefit of decreasing the workload of the heart through less circulating blood volume. It also increases urine output, which can help with decreased renal function. But we have to monitor intake and output. We have to monitor potassium levels. We've got to monitor weight and vital signs. We have to assess for hearing loss, particularly with Lasix. We have to tell these patients to take this medication early in the day to avoid nocturia. And we need to tell these patients to drink plenty of fluids to avoid dehydration and confusion. Rise slowly when they are changing positions to avoid orthostatic hypotension. All of them, except for the potassium sparing, we want them to eat a potassium-rich diet. I think those are the key points that you really have to have drilled into your head when you have a patient on a diuretic. So from there, let's talk beta blockers. So before we give a beta blocker, we want to assess the apical heart rate and the blood pressure, because beta blockers will slow the heart rate and lower the blood pressure. After we give a beta blocker, you want to assess for a decreased pulse rate. They should have decreased cardiac output and a decreased blood pressure. Beta blockers block the effect of adrenaline on the beta receptors in the heart, and that is also part of the heart conduction as well. And that's why you've got a slower heart rate and a lower blood pressure. These can cause orthostatic hypotension. They can cause bradycardia or even a heart block. These can cause heart failure, chest pain, fluid retention, nausea, vomiting, diarrhea. They can mask the signs and symptoms of low blood sugar. We should never abruptly stop taking a beta blocker because it can cause rebound hypertension, chest pain, arrhythmias. If a patient has bradycardia, a pulse less than 60, you need to take a look at their med list and assess for use of a beta blocker. Of course, what I touched on a couple slides back with beta blockers, how there's beta 1, beta 2. Does your patient have a history of a respiratory problem? And are they having any adverse effects like bronchoconstriction or bronchospasms? So I think those are the key things with those beta blockers. Just to describe what it does in another way to help you understand it, is the beta blockers decrease blood pressure in the blood vessels, and they also block the beta receptor sites in the heart, muscle, and conduction system, which decreases heart rate and reduces the force of heart contraction, which lowers the oxygen demand. And that is why it's helpful and commonly prescribed after a heart attack or even during an acute heart attack. Metoprolol, atenolol, labetalol, all of those are cardioselective beta blockers, but they still can carry the potential risk of bronchoconstriction. Propranolol is not cardioselective, so we can't use that in people with COPD or asthma. All right, let's talk calcium channel blockers. What do they do? So calcium channel blockers block the passage of calcium ions across the heart cell membrane and smooth muscle cell membrane. This causes dilation of the coronary and peripheral arteries, which decreases the workload of the heart and decreases heart contractions. Calcium channel blockers are commonly used to treat chest pain, such as stable angina. They can be used as an anti-arrhythmia medication or for hypertension. Some examples are ditalazam, verapamil, amlodipine. Those are very common ones. They are super good at controlling the rate, the heart rate, slowing it down. Like, let's say your patient is having atrial fibrillation. They could be prescribed ditalazam. And atrial fibrillation usually is going too fast. It's greater than 100 beats per minute. Ditalazam will slow that heart rate down and allow for better cardiac output. Very important to understand that. From there, we've got our ACE inhibitors. Remember, these all end in pril. And oh, I apologize. I forgot to remind you with the beta blockers, they all end in OL. So our ACE inhibitors all end in pril. What do? They reduce blood pressure by interrupting the renin-angiotensin-aldosterone system. That works to clamp down or constrict and retain fluid and sodium. Specifically, ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2. This causes dilation and lower peripheral vascular resistance. Just a reminder, I'm going to just review the renin-angiotensin-aldosterone system with you because it's so important to understand. So this is the sequence of events. Number 1, your kidneys release renin to help maintain a blood pressure. Step 2, renin acts on angiotensogen to form angiotensin 1. Step 3, angiotensin 1 is converted into angiotensin 2. Step 4, angiotensin 2 is a potent vasoconstrictor, and it increases peripheral resistance and promotes excretion of aldosterone. Step 5, aldosterone promotes retention of sodium in water, increasing the blood volume and the workload of the heart. So let's circle back around. I told you that ACE inhibitors work by interrupting the renin-angiotensin-aldosterone system. Specifically, they prevent the conversion of angiotensin 1 to angiotensin 2. So if we stop steps 2 and 3, step 5 never happens. So just to throw that out there. And to contrast that, let me just talk about angiotensin 2 receptor blockers. They affect the renin-angiotensin-aldosterone system too, but they affect a different step in the process. They block the binding of angiotensin 2 to receptor sites, and then that stops the aldosterone phase. Okay, so let's get back to ACE inhibitors. What do they do? What are the important things to know about ACE inhibitors? Okay, they are useful in treating heart failure and hypertension. They're going to dilate the blood vessels. They're going to lower blood pressure, so blood flows easier and the workload of the heart decreases. There are some side effects. The most common are orthostatic hypotension or a dry, nagging cough. If your patient has a dry, nagging cough, it can be so bad that they need to go off of this medication. And if they need to go off this medication, what we usually switch them to is the angiotensin 2 receptor blockers. Because they affect a different part in the cascade, they don't have that side effect of the dry, nagging cough. These are a newer generation of drug, so they are typically a little bit more expensive. But there are generics available still. And what they do is they lower blood pressure by blocking the vasoconstriction effects of angiotensin II. They are used as an alternative treatment to an ACE inhibitor, commonly for heart failure or hypertension, and they tend to end in sartan. Two examples would be losartan and valsartan. All right, hang in there, guys. We're nearing the end. I want to touch base on vasodilators. There are a variety of vasodilators. Nitroglycerin is one. Another example is isosorbide. Another is hydralazine. Nitroglycerin and vasodilators relax blood vessels, and by relaxing blood vessels, it increases the supply of blood and oxygen to the heart. These are used for people that can't tolerate other treatments, for example, an ACE inhibitor. These help to relieve chest pain and lower blood pressure. There is common side effects of nitroglycerin, particularly the fast acting can cause acute dizziness and headache. Usually we treat the headache with Tylenol. Usually we prevent the dizziness by having them take the first dose when sitting or lying down. Nitroglycerin, the quick release is for acute chest pain. The slow release is more for chronic angina or blood pressure control. Okay, then let's talk cardiac glycoside. Whenever you hear cardiac glycoside, you should think digoxin. Digoxin is super helpful in treating atrial fibrillation and lesser commonly heart failure. It inhibits the potassium and sodium pump that suppresses AV node conduction, and it increases heart contraction force. So it's super helpful for irregular heart rates or weak heart muscle. The most common use is heart failure. It can be used for AFib, but we've found that there's other drugs that work better as first-line treatment. It does have an antidote. The antidote is Digibind. Cardiac glycosides, specifically digoxin, is a positive inotrope, and it strengthens the heart muscle contractions. And it just makes sense. That's why it helps so much in heart failure. Because heart failure, you have an ineffective pumping, your muscle is weak. Digoxin will help strengthen that and increase the contraction force. Let's see. Digoxin does have some possible side effects. I would say vision changes, headache, dizziness. Those are red flags that possibly they have too much digoxin in their system. Digoxin can also lower heart rate or cause a heart block, and that is why we need to assess the pulse apically for a full minute before we ever give a dose of digoxin. Typically, if their pulse is 60 or less, we would hold the digoxin dose, reassess, and then notify the provider if we cannot give the dig safely. Let's see. I think those are the key points. One other thing I do want to add is digoxin has a narrow therapeutic index, so we will check serum drug levels periodically to ensure that they're in a safe range, and we will do a serum drug level check if they report any of those side effects. All right, and then my last thing I want to touch base on is some common cardiac meds. Definitely know these. So digoxin, commonly used for heart failure. Amiodarone, commonly used for arrhythmias. Coumadin, commonly used for atrial fib. Metoprolol, it's a beta blocker, super helpful, very commonly prescribed for heart attacks, after heart attacks, hypertension. Verapamil, calcium channel blockers, super commonly prescribed for hypertension, and we can use it for arrhythmias too. So meds are super important to be familiar with, and I hope that this review was helpful. Please let me know if you have any questions, and this concludes my record seminar. Thanks so much for listening.